So again, we're talking about the 3 phases of healing, the inflammation, repair, remodel phase. And let's go into some of these main points here. So the physiology of the science of the 3 phases of healing. So we're looking at the inflammation phase. So what are we typically trying to do, and what's the body trying to do in the inflammation phase? So this is where it's trying to fight infection, clear debris, okay? So some of these titles are kind of important. Like this one, homeostasis. Starts the healing process. Clotting cascade takes place to obtain homeostasis or stop blood loss by way of a fibrin clot. So you're going to have minor trauma or major trauma. Typically in personal injury, it's going to be major trauma. Okay? Some of these words are important, like cytokines, fibrin. Okay? So chemokines and cytokines are released to attract cells that phagocytize debris, bacteria, and damaged tissue. So these are some important words. Chemokines and cytokines also release signaling molecules that initiate the proliferative phase of wound healing. Now this is really important. NSAID, non-steroidal anti-inflammatories, block cytokines and prevent the proliferative phase of collagen synthesis. You've heard me say this before. One of the reasons we want to know if the patient is taking ibuprofen, and the reason you don't want the patient taking ibuprofen during the healing phase, is especially the repair phase when collagen is being synthesized. This is why right here, is because NSAIDs block cytokines from synthesizing collagen during the repair phase, which if it heals that way, it permanently heals weak. Okay, this is why right here. All right, so now we go to, after the homeostasis, then we go to the clotting cascade. So now we're going, so that was the clot. Now remember, this all happens on a micro scale also. Whether it's 1 injured cell, 10 injured cells, 100 or 1,000 or 1,000,000 injured cells. The same process happens whether it's 1 cell or 1,000,000. It's just the degree that it happens, and then what is the quality of the tissue that's being affected. So the clotting cascade from clot to collagen. So after an injury, blood contracts collagen, triggering blood platelets to secrete pro-inflammatory chemicals. So platelets along the fibrin and fibronectin form a plug that prevents blood loss and is the support until it is replaced with granulation tissue and later collagen. So granulation tissue is the precursor to the collagen. Okay? Platelets release proteins and cytokines and pro-inflammatory factors like serotonin, bradykinin, prostaglandins, prostacyclins, thromboxane, and histamine. So the platelets release the proteins and the cytokines and pro-inflammatory factors. Cytokines is a big word right here. Pro-inflammatory factors increase cell proliferation and cause blood vessels to become dilated and porous. So these cytokines are important. Okay, so they create pro-inflammation, cause blood vessels to become dilated and porous. Now, vasoconstriction and vasodilation. Remember, this is clinically, this is everything that you're trying to do. This is what you're trying to measure with your tests and your diagnostics. This is what your therapeutics are about. This is what everything is about, what you're trying to do right here. This is the level at which you got to be thinking therapeutically. So vasoconstriction, vasodilation. So immediately after a blood vessel is injured, cell membranes release inflammatory factors like thromboxanes and prostaglandins that cause the vessel to spasm to prevent blood loss. So the vasoconstriction lasts 5 to 10 minutes and is followed by vasodilation. So initially on the injury, there's constriction to shut down the blood loss, followed by 5 to 10 minutes of vasodilation. So vasodilation mainly from histamine released by platelets also causes blood vessels to become porous, allowing proteins from the bloodstream to leak into the extravascular space, drawing water. Okay, vasodilation and histamine, big factors right here. All right, then we come into the neutrophils, infection control and injury cleaning. So the neutrophils are attracted to the injury by fibronectin, growth factors, and kinins. Neutrophils phagocytize debris and kill bacteria while cleansing the injury and secreting proteases that break down damaged tissue. See, so we're walking through the healing process here. Neutrophils usually undergo death once they have completed their task and are engulfed by macrophages. So there's your neutrophils, your white blood cells. Macrophages. Cleaning the injury, macrophages. Macrophages attracted by growth factors released by platelets replace neutrophils as the predominant cells in a few days after the injury. So macrophages come in, replace the neutrophils. Macrophages' main role is to phagocytize bacteria, damaged tissue. Macrophages also secrete growth factors and other cytokines that attract cells that are involved in the proliferative stage of healing. So the macrophages secrete growth factors and other cytokines that attract cells involved in the proliferative stage of healing. What's the proliferative phase? That's the repair phase. That's the collagen synthesis phase. Macrophage playing a role right there. Macrophages are stimulated by the low oxygen content of their surroundings to produce factors that induce angiogenesis. So here we have blood vessels starting to form. What's the reason? Macrophages start to form them. Why? Low oxygen content from the injury. Low oxygen content is what starts the new blood vessels. Macrophages also stimulate cells that re-epithelialize the injury, create granulation tissue, and lay down new extracellular matrix. So we have the beginning stage of scar tissue, granulation tissue, extracellular matrix, and macrophages push the injury healing process into the next phase. So the decline of the inflammatory phase. Macrophages must be reduced. So as the inflammation dies down, fewer inflammatory factors are secreted and neutrophils and macrophages are reduced. These changes indicate inflammatory process is ending and the proliferative phase is underway. See, so this is microscopic. These changes microscopically indicate the inflammatory phase is ending and the proliferative phase is underway. The presence of macrophage delays injury contraction, and so the disappearance of macrophage from the injury is essential for subsequent phases to occur. Pretty important. The presence of macrophage delays injury contraction, and so the disappearance of macrophages from the injury is essential for the phases to occur. Inflammation plays roles in fighting infection, clearing debris, inducing the proliferative phase. It's a necessary part of healing. Inflammation can lead to tissue damage if it lasts too long. The reduction of inflammation is frequently a goal of therapeutic settings. The presence of debris can extend the inflammatory phase for too long, leading to a chronic wound. So we know the inflammation, long-term inflammation, is bad. So then we come into the repair phase and proliferative phase. So about 2 or 3 days after the injury occurs, fibroblasts begin to enter the injury site, marking the onset of the proliferative phase, even before the inflammatory phase is ended. So remember, we said 6 to 12 weeks, so it starts way sooner. We're looking at a peak, and we do it for communication purposes also. Where's the peak of the proliferative phase? The bell curve. And it's easier to pick certain numbers than it is to be vague in general. As in the other phases of injury healing, steps in the proliferative phase do not occur in a series, but rather partially overlap in time. And I say this all the time, that it is not black and white. And it's totally based on the biomarkers. So that's why you can have biomarkers that are inflammatory, you can have biomarkers that are in the repair phase. Your therapeutic protocol is going to be based on your biomarkers. Angiogenesis. So now we have our new vascularization occurs along the fibroblast proliferation when the endothelial cells migrate to the injury. So the new circulation is occurring. Angiogenesis is imperative for fibroblasts and epithelial cells that require oxygen and nutrients, and typically looks red due to the presence of capillaries. Stem cells of the endothelial cells originating from the uninjured blood vessels grow into the injured site to establish new blood vessels. So where do these blood vessels come from? They come from stem cells. Where do the stem cells come from? The endothelial cells. What stimulates that? Lack of oxygen. Endothelial cells are attracted to the injured area by fibronectin and angiogenic factors released from the macrophages and platelets. Endothelial cells. Endothelial growth and proliferation is directly stimulated by low oxygen and the presence of lactic acid. We know that lactic acid is released also, so it's a stimulatory effect of angiogenesis. To migrate, endothelial cells need collagenases and plasminogen activator to degrade the clot and allow cell migration, proliferation, and angiogenesis. When the macrophages and other growth factor producing cells are no longer hypoxic or in lactic acid environment, they stop producing angiogenic factors. So during that healing process, the lactic acid, lack of oxygen, that's what stimulates angiogenesis. New vessels, plasma and granulation, tissue formation. Remember, we're in the repair phase right now. So now it's the fibroplasia and granulation. New tissue, fibroblasts, are the main cells that lay down the collagen matrix, fibroblasts. Granulation tissues consist of new blood vessels, fibroblasts, inflammatory cells, endothelial cells, myofibroblasts, and the components of a new provisional extracellular matrix. Remember, all this is happening. All of this is happening every time there's an injury. The degree at which has happened and it restricts or limits your sensations is when it becomes important. The degree, but it's always happening. 1 cell, 100 cell, 1,000 cells. Fibroblasts begin entering the injury 2 to 5 days after the injury as the inflammatory phase is ending. Their numbers peak at 1 to 2 weeks post-injury. By the end of the first week, fibroblasts are the main cells. Fibroplasia ends in 2 to 4 weeks after the injury. Fibroblasts are the main cells that lay down a collagen matrix in the injury site. Remember, that's if there's no further irritant. And there's no such thing as no further irritant because we live in a dynamic world. We are not static. Fibroblasts are from the adjacent uninjured tissue or blood-borne circulating adult stem cell precursors. Initially, the fibroblasts utilize the fibrin cross-linking fibers to migrate across the injury, subsequently adhering to the fibronectin. So these are the collagen strands we're talking about. Fibroblasts then deposit ground substance into the injury and later collagen, which adhere to for migration. So the granulation tissue functions as rudimentary tissue, begins to appear in the injury during the inflammatory phase. So the precursor to collagen is the granulation tissue, 2 to 5 days post-injury, and continues growing until the injury is covered. Granulation tissue consists of new blood tissues, fibroblasts, inflammatory cells, endothelial cells, myofibroblasts, and the components of a new provisional extracellular matrix. The provisional type 3 collagen matrix is different in composition from the original type 1 collagen matrix in normal tissue, and its components originate from fibroblasts. Type 3 collagen from type 1, from fibroblasts. Fibroblast components include fibronectin, collagen, glucosamine, glycans, elastin, glycoproteins, proteoglycans. So its main components are fibronectin, hyaluron, which create a very hydrated matrix and facilitate cell migration. Later, this provisional matrix is replaced with a collagen matrix that is more closely resembles that of found in non-injured tissue. Growth factors and fibronectin encourage proliferation, migration to the injury, and production in collagen matrix by fibroblasts. So this is what everybody's trying to control with therapeutics. How is all this being laid down? Hypoxia also contributes to fibroblast proliferation and the excretion of growth factors. Too little oxygen will inhibit their growth and deposition of collagen matrix components and can lead to excessive fibrotic scarring. So that's a lot about the collagen. Now we go to collagen deposition and tissue strength. This is during the repair phase. Collagen deposition is important because it increases the strength of the injured tissue. Fibroblast's most important duty is the production of collagen. Before collagen is laid down, the only thing holding the injury together is fibronectin clot, which does not provide much resistance to trauma. Cells involved in inflammation, angiogenesis, and connective tissue construction attach to, grow, and differentiate on the collagen matrix laid down by the fibroblasts. So this is everything we're trying to influence with therapeutics. Type 3 collagen and fibronectin are generally beginning to be produced in appreciable amounts somewhere between approximately 10 hours and 3 days, depending on the injury. Type 3 collagen deposition peaks in 1 to 3 weeks. There are predominating tensile substances until the later phase of maturation or remodel phase, in which they are replaced by the stronger collagen. Even as fibroblasts are producing new collagen, collagenases and other factors degrade it. Shortly after an injury, synthesis exceeds degradation, so collagen levels in injury rise, but later production and degradation become equal, so there's no net collagen gain. This homeostasis signals the onset of the latter maturation phase or remodel phase. Let me say that again. Shortly after the injury, synthesis exceeds degradation, so collagen levels in the injury rise. But later production and degradation become equal, so there's no net collagen gain. That's the beginning of the remodel phase. Granulation, or the reproduction of new tissue, gradually ceases, and fibroblasts decrease in number in the injury once their work is done. So there's no more synthesis in that repair phase. Now we're on to the remodel phase. Synthesis of collagen is done. Remodeling phase or maturation strengthening phase. When the levels of collagen production and degradation equalize, the maturation phase of tissue repair begins. During the maturation phase, type 3 collagen, which is prevalent during proliferation, is replaced by type 1 collagen. Originally disorganized collagen fibers are rearranged, cross-linked, and aligned along tensile lines. That's what chiropractic is trying to do in active, passive, and joint motion right there. The start of the maturation phase can range ranging from 3 weeks to past a year or longer, depending on many factors, including therapy and complicating factors. As the maturation phase progresses, the tensile strength of the injured collagen increases, approaching 50% of the normal tissue to 3 months after the injury, and ultimately as much as 80% of normal tissue. So the phases of injury of healing normally progress in a predictable, timely manner. If they do not, healing may progress inappropriately to either a chronic or permanent injury. So I just wanted to take time out to highlight some of these histological phases in the inflammation repair remodel phase. And the reason I wanted to do that is so often we don't even think of that. As clinicians, we're not even thinking of any of that. We're not thinking of fibrin, fibronectin, and all this stuff. And that's what we're doing. Everything that we just talked about is what we're trying to do as clinicians. We're trying to affect the outcome of those 3 phases of healing optimal to the patient. Whether it's in the inflammatory phase with therapeutics, decreasing the inflammation, the pain signal, to affecting the collagen, the fibrin, all that from active, passive, and joint motion, to affecting the elasticity and strength in the remodel phase. So this is it. On a physiological level, this is what we're trying to do therapeutically. as physicians, and sometimes we forget this. We forget this. This isn't even paid attention to. And this goes into the conversation that I just talked about earlier. Everything you do clinically is going to be based on these factors predominantly. Number one, what's the history of the patient? There could be some history to the patient that affects the outcome. Okay? There could be some genetic issues involved, etc. What's the mechanism of injury? Major, minor trauma, genetic. What were the injury magnifiers? These all play a role. Then it goes into what were the biomarkers? What were the subjective biomarkers? And there's a whole list. What are the hybrid biomarkers? There's a whole list. What are the objective biomarkers? And we already know some biomarkers are really sensitive for certain conditions, and some aren't sensitive at all. An MRI is worthless for spinal dynamics, for spinal biomechanics. It's worthless. It's great for a disc bulge. So the right test for the right problem becomes pretty important. So there's your therapeutic protocols relative to which phase of the healing we're in. And then what are the complicating factors? Well, there's some common complicating factors and some that aren't very common. And there's your protocol. That's why you're doing everything you do. You're trying to be a better detective. You're trying to have more specific testing, more sensitive testing, to actually find these problems and quantify them. Because that quantification determines, is it getting better, worse, staying the same? And as a clinician, this is what we're doing every day. And sometimes I wanted to take time and go over that because I feel like this is never in the conversation. People forget. This is what you're going in the office from a clinical perspective. These are the reasons why you're doing what you're doing every day in your office, clinically.